webinar. This is the third of our series on safe opioid prescribing, and the focus today is going to be on teaching safe prescribing to primary care residents. We're very excited to have a great faculty together for this program. What I'd like to do is briefly go through why the California Healthcare Foundation is interested in this topic, a little bit of background, introduce our speakers, and then I'm going to be handing off the mic to Christine Cristobal, who will be facilitating our webinar today. The California Healthcare Foundation is starting new work in the area of the opioid epidemic as part of our focus on patients with complex behavioral healthcare issues that drive high medical costs and poor outcomes. And although there's been a lot of focus around California on emergency departments adopting safe prescribing practices, most opioids are actually prescribed by primary care providers. However, the new programs that are generating new primary care providers, our residency training programs, often don't have the capacity, the curriculum, or the infrastructure to really teach residents how to do this well, how to compassionately care for a complex population, use opioids judiciously and safely, using them when they're indicated and not using them when they cause more harm than good. So in addition to the webinar today, we're going to be launching a Residency Safe Prescribing Action Group, which is a collaborative where 9 residencies across the state will be joining to learn how to create a clinic infrastructure supporting safe prescribing and also a curriculum to teach residents. And of course, we'll be sharing what we learn in the, after the action group is finished. We have 3 faculty today. Christine Cristobal is our facilitator, and she's a consultant working with CHCF on our opioid initiatives and has special expertise in pain management practice coaching, and she'll be also leading the Residency Action Group. Diana Coffa is the Residency Program Director for the UC San Francisco Family and Community Medicine Residency Program at San Francisco General, and she specializes in the intersection of chronic pain and substance use disorders in primary care. So she's created curriculum, taught in multiple residency programs, served as the chair of the Department of Public Health Pain Education Committee. She leads a chronic pain treatment group, which she'll be telling us about, runs a medication-assisted treatment program or buprenorphine treatment program, and is also published in this area. Soraya Azari is an Associate Program Director for the San Francisco General Primary Care Track as part of the UCSF Internal Medicine Residency. Also has a special interest and expertise in chronic opioid therapy, addiction, and quality improvement efforts. She served on the task force for the San Francisco Health Network's Chronic Pain Committee and has been an educator in countless training on the areas of chronic pain and substance use disorder. She also works at the opioid treatment outpatient program treating patients with substance use disorders. So I'm delighted to welcome Dr. Coffa and Dr. Azari to the program, and I'll be handing over the mic to Christine.
Hi, everybody. It's Christine Cristobal, and I'll be facilitating the rest of the call for you. Let me go over just a few housekeeping items. We are recording this webinar session, and it will be on the CHC website in about a week. And you see the URL there on the screen, and feel free to share that with any of your colleagues who weren't able to make it today. Because we do like to minimize the background noise, the way we are going to have questions asked is through our chat function. And if you're unfamiliar with chat on the WebEx platform, you should see, I believe it's a bright blue chat button. It looks like a little dialog box in your upper right-hand corner of your screen. And if you click on that, a chat box should open up in the bottom right of your screen. If you have any logistical questions at all about the WebEx platform, please feel free to send your chat to the host. You can click on the little drop down there and you can send your logistical questions to the host. Now, if you have questions for speakers, I will be curating all of those questions and be asking it to our presenters for you. You can send those questions to all attendees. So any comments or questions you have are very, very welcome. What we have been doing, which has worked very well, is that from about 12:30 to 1:30, we're going to hear from our speakers and their main presentations, about 20 minutes each. We'll address your questions as they come through the chat box. And then we are able to, and grateful to have our experts staying on from about 1:30 to 2 o'clock, We'll open up the lines for any of your additional questions or more discussion. But of course, you're welcome to log off at around 1:30 when the official presentation component will be done. There will also be a very short evaluation that will pop up at the end of the webinar. So a little bit before 1:30, you'll see some questions popping up for you to answer. And if you can give us some feedback on your experience of the webinar, it would help us greatly, and we always continue to improve these offerings for you. So at this point, I think that is it for the logistics. I'd love to hand it over to Diana.
Great, thank you. So welcome. It's always strange to present to people who you can't see. And of course, the most useful part of this is going to be the question and answer, when you can talk about your own situation and we can help you think about how to move forward in the situation you're in. So for that reason, and knowing that you're going to have these slides available to you, I'm going to intentionally move pretty quickly through these slides so that we can have a decent amount of time to actually talk together. So let's see. Moving forward here. So I'm going to spend a little bit of time just defining the problem. We all know that there's a problem around chronic pain management, and sometimes it helps to articulate exactly what its nature is. So even before opioids became an issue, before people were using opioids for chronic non-cancer pain on any kind of large scale, there was a whole body of literature in medical anthropology about how much doctors disliked chronic pain patients. Starting in the 60s and 70s even, and up through the 90s, there were people who made their careers studying how much doctors don't like chronic pain patients. Elaine Scarry wrote a book called The Body in Pain, and this is one of my favorite quotes from that book. To hear about pain is to have doubt. To experience pain is to have certainty. And it's true, when we hear somebody describe their pain, we have virtually no idea what they actually mean. Do they mean that they're having depression and they're calling it pain? Do they mean that there's a trauma that's being held somewhere and they're calling that pain? Do they mean that it's tingling or burning? Or we really don't know what people mean when they say pain. And there's this inherent doubt in hearing somebody talk about their pain. And the opposite of true is true of the experience of pain. You know exactly what you're feeling, and there's no question about it. And so we stand across this chasm with our patients when they're telling us about their pain. We don't understand them, and they can feel that. And we as providers have historically found that very frustrating. And then, starting in the 90s, we began prescribing opioids for patients who have chronic non-cancer pain. And for a while, it felt really good because we were finally making people feel better. And then in the mid-2000s, we began to realize that we had created a whole other problem and that a whole other kind of suffering was being generated by our treatments. This image is, I don't know how many of you know the rapper Eminem, but he was big on the rap scene in the 90s. In the mid-90s, went into recovery, actually, from drug use. And then in early 2000, he released an album called Relapse, and the B-side is called Refill. And the album cover was actually a picture of his face made out of pain medications, pain pills, which I use just to highlight how completely mainstream the use of prescription opioids was, even in this was in the early 2000s when he came out with this album. You'll be happy to know his latest album was called Recovery, and it's much better than the Relapse album. So prescription opioid misuse became much more common in the early 2000s, mid-2000s. By 2010, 2011, we had really started as a field trying to turn the boat around, slow down our opioid prescribing, and stop this overdose epidemic that was occurring. And we have had some success, actually. We're starting to see a decline in new initiates of prescription opioid use. So we're making some progress, and at the same time, we're actually, in my opinion, starting to swing the pendulum a little too far, maybe, such that we have now some providers who, once again, won't prescribe any opioids to anyone, which is probably further over than we need to go. And so our poor residents find themselves in this situation where every provider has a different opinion, and a different experience, which makes it really tough to learn. So doctors fundamentally, because of all of these things, often don't like caring for patients with chronic pain. It's hard to be good at something you don't like to do, and so we often struggle at it. It's hard for learners to learn about something that their teachers don't seem to like. And it's really hard to empathize with a patient who you wish wasn't in the room making you feel bad about the work that you do. And residents have a particular vulnerability, as I think you know. There are emotional differences to being a resident. They're more vulnerable to feeling overwhelmed by these complex patients. They're less likely to be able to distinguish between pain and addiction. They're much less tolerant of patient dissatisfaction than we are. If a patient tells me I'm a bad doctor and yells at me and calls me cruel, I at least know who I am and that I'm a good doctor. It's much harder for someone who's early in training to tolerate a patient getting angry at them. So these patients are, I think, even more distressing for young doctors. Residents are more compelled to fix things that they may not be able to fix. And truly, they're less jaded, which is a good thing, and also makes them more sensitive and vulnerable and makes these patients in these situations all the more difficult. Keep trying to advance with my mouse. There are also logistical differences in residency that we need to address. So residents can find themselves with different preceptors who have different practices, and the poor patient ends up getting whiplashed from one plan to the next, depending on which preceptor precepts the resident. There may be difficulty setting up good continuity if residents have schedules that are constantly changing. So patients may have difficulty getting seen as frequently as they need to if they're on a controlled substance that requires monitoring. And then you get residents who, as you know, have had variable training in medical school. So some will have been taught, treat the patient with opiates until the pain score goes to 0. And others will have been taught, don't treat to pain score, treat to function, and treat to improve the patient's function. So you're going to see very different things coming out of medical school these days because we have such a disparate set of opinions about how to manage pain. So I'm going to talk specifically about 3 strategies that we have used to help handle all of this complexity. One is to develop a really consistent policy that everybody in clinic follows, so there's less of this whiplashing between different providers. 2 is to actually institute a review committee in clinic that reviews patient cases and helps back up providers who need some backup or clear things up for providers who need some clarification. And then lastly, to have the residents rotate through a pain support group so that they can actually maintain that empathetic, unjaded, curious stance that they enter residency with. So we're going to start by talking about the policy. These slides have a lot of words on them, and what I'm going to do is really focus on the heading areas and let you dive a little deeper into the details if you are working on building a policy for your own clinic. What I'm going to do is focus on the things that should be addressed in a policy about chronic pain management. So a clinic should address in the policy, what do we include in initial assessment of pain? We should make sure to include some assessment of risk for addiction or overdose. There are some standardized assessment tools. I use the opioid risk tool, which is a nice, simple 5-point risk assessment tool that allows you to be objective. The reason this is really important is that our guts are terrible at telling us who's at risk and who's not. We tend to believe that Black people are more likely to misuse than white people. This has been shown in multiple studies that that's what providers believe, and providers are wrong. It's actually true that white people are more likely to misuse than Black people. So I tell this to my residents, and I tell them, do not trust your gut here. Trust an objective tool. Keep yourself from making assumptions that are inaccurate about people. We also encourage people to assess patient function. Rather than focusing so much on the pain score, what are the functional measures we can assess? And to broaden people's thinking, it's useful to actually list out physical function, emotional function, social function. How's your patient sleeping? This allows providers to focus on other areas that might be amenable to non-opioid treatment options. You then want to give some advice about how frequently to reassess and what to reassess for in your reassessment visits. You want to have a really clear refill policy. Do you allow early refills, and in what circumstances? Who can write refills, and how is that communicated to the primary care provider? You want to have clear guidelines about monitoring for misuse. We recommend, and it's sort of standard of practice, to do a universal precautions approach where every single patient on opioids, no matter if they're 85 years old and a little old lady you believe would never, you still do a urine drug screen and a cures report at least once a year for every single one. And then based on risk assessment, you increase the frequency for people who are higher risk. It's then really useful, particularly in a teaching setting, to have a really clear set of guidelines about how to respond to concerning behaviors. Now, I want to just make a point about language here. I don't call them contract breaks. That, to me, brings a very legalistic approach to the problem, and I think of it as a medical problem. I think of that when I see a concerning behavior, for example, a patient is requesting early refills on a repeated basis, to me, that means they might have a problem. They may have an addiction that I might need to help them with. So I am concerned for them, not angry at them. I deliberately use that language with residents. We teach them to build a differential diagnosis for these behaviors. So a patient presents requesting an early refill. What's your differential? It's possible that the medications were actually stolen. It's possible that the patient has an addiction and used all the medications in the first week. It's possible that the patient sold the medications. It's possible that the patient's in a lot of pain and is taking more than prescribed because of that. And we actually have residents write out that differential, think about what is probably at the top, right, just like we do with any other problem, and then decide, do they need to do more diagnostic testing, or do they need to go ahead and take action? And we'll talk a little bit more about what our options are in the next slide. One of the things that's almost always on your differential is addiction, and that's why a good curriculum on addiction is critically important to these conversations about opioids. Residents need to understand that addiction is a chronic disease, not a moral issue. So when a patient is falling into those habits, it's not a betrayal or a moral failing. It's a disease that you've now diagnosed and are obligated to help treat. For that reason, when we discontinue opiates, we want to pair it with a referral to substance use treatment, including medication-assisted therapy, which is the most effective form of therapy for opiate addiction. And we never, ever fire our patients because they've developed this disease, right? We stand by their side and help them get through it. I use the analogy here. So when I'm trying to help residents maintain some compassion through these tough conversations with patients, I'd use the analogy of lisinopril, right? If a patient on lisinopril had a blood pressure of 90/40, I would discontinue the lisinopril because I was harming the patient. In the same way, if a patient starts to display addictive behaviors on my opiates, I discontinue the opiates because I'm harming the patient, not because the patient's a bad person or did something wrong, but because I'm harming them and I need to stop and I need to change my treatment plan. That compassionate stance makes it much easier for residents to have difficult conversations about discontinuing medications. And we use language like, I'm concerned about you, I want to keep working with you, we can find a way through this. I care about your safety, and so opioids are off the table, but there are lots of other pain medicines and treatments on the table that we can talk about. I'm sure many of you are really skilled at this. We give really clear options for response in our clinic policy. So for example, we recommend immediate discontinuation if the prescription opiate is clearly being diverted or if somebody has forged or falsified a prescription. That's kind of a no, we don't cross that line. If we're not sure what's going on, if we're not sure of the cause of the behavior, then we increase monitoring. So we bring the patient back in more frequently, we do more frequent urine drug tests, we check a cures report, and we try to narrow our differential diagnosis. If it's become clear to us that the patient has an addiction or is at high risk of overdose, then we recommend tapering opioids and providing medications to help with withdrawal symptoms. And of course, referring to substance use treatment if that's the diagnosis you've made. We also have a whole separate section, and we recommend people do, on how to respond to abnormal urine drug tests. There are a variety of categories of abnormal urine drug tests. You can see I listed them out. The prescribed drug is absent. There are non-opioids like cocaine or methamphetamine in the urine, or there are non-prescribed opioids in the urine. And each one of those has a slightly different differential diagnosis. I'll let you read through the slide. The one thing I want to highlight is that a lot of people are conflicted about patients who have cocaine, for example, in their urine and are prescribed opioids. There are some who say you should discontinue for that, and others who say, well, why wouldn't someone with a cocaine addiction also have chronic pain and need opioids? Why should I discontinue the opioids? And I just want to give a little bit of information that I think is really important here. We know that the risk of overdose is much higher when people combine stimulants like cocaine and methamphetamine with opioids. We don't know why, but we know epidemiologically that people are much more likely to overdose when they combine the two. We also know that the risk of diversion is increased in this situation. So if you have told a patient, you can't have cocaine in your urine or I will stop prescribing, and they're unable to abstain from cocaine for 3 days before seeing you, which is how long it takes for it to leave the system, that suggests that they're not entirely in control of their cocaine use. And if they're that out of control of their cocaine use, the chances that they're selling the opiates you're giving them to buy their drug of choice are actually very high. So for those two reasons, we typically do recommend discontinuing opioids, tapering them in the setting of ongoing stimulant use. There is room, for example, for a policy to instead require that people enter drug treatment, right? So there's room for flexibility. And so I'm actually going to pop back for a second. And so I want to talk just a little bit about the process of building a policy. Because there's so much room for different ways of doing things and room for flexibility, what we recommend is taking a very collaborative approach to building your clinic's policy. We, in our own clinic, had physicians, nurse practitioners, physician's assistants, nurses, medical assistants, clerks, and psychologists all involved in building the policy. It went through about a dozen iterations. And then by the time it was finished, we actually had every single person in clinic read it and sign off on it. So that kind of buy-in is really critical on such a controversial issue. Okay, so the next thing I want to talk about is how we kind of make this real, right? People can read a policy and then ignore it. And so we have a Controlled Substances Review Committee in our clinic. We call it the Pain Squad, hence this image, and we do sing a soundtrack sometimes. We have two primary tasks. We review patient cases, and then we also develop policy and manage quality improvement projects throughout the clinic around pain. So when we do a case review, we solicit referrals from providers, nurses, medical assistants, clerks, really anyone in clinic who is worried that a patient might be misusing prescribed opioids, worried that the patient might be at risk for overdose, or worried that there's inadequate pain control and is looking for something else. We also do case finding. So we have a registry of patients on opioids, and we look for patients who have a positive urine drug test or who are on very high doses, or patients who request transfer to another PCP. We will actually reach out and review those without referral. The review committee, will review the patient's medical record, look at what medications they're on, look at what non-opioid pain management they've had. We'll do an opioid risk assessment using a standardized tool. We'll look for a history of concerning behaviors, and we'll look at social and psychological factors. And then our team of psychologists, nurses, medical assistants, clerks, we have a data manager for the registry piece, and clinicians will all review the case. We also invite the primary care provider to join us for the discussion. And we come up with some recommendations. And the basic framework we use is what I call the 4-quadrant framework. So we want to make sure that every patient who has chronic pain is receiving treatment from each of these 4 categories, or at least has been offered treatment from each of these 4 categories. And the reason we do that is we really want it to be clear to everyone in our clinic that opioids are a tiny, tiny, tiny part of pain management, and that you can discontinue opioids and still be a good pain doctor for your patient. So what we do is, as we're discussing the cases, we actually have this form that we fill out where we put a little check next to our recommendation, and then we'll write some text next to it. So for example, if I recommended tapering opioids, I would put a check next to taper, and then I would actually write out recommendations about how to taper and what to consider while tapering. You can see that we have a lot of options for procedures, movement-based therapy, psychological therapies, alternative therapies, and we've made this form based on what we have available in our clinical setting. So you, if you made a committee, would make your own form. We also have a section about substance use disorders. If we think that that's what's happening, we'll make some specific recommendations about where to refer and what to think about. For every patient on opioids, we recommend, you'll see the last item in the table is prescribing naloxone. We recommend every patient with opioids have naloxone at home to reverse in case of an overdose, and I think Dr. Azari is going to talk about that more in her section. So that's our Controlled Substance Review Committee. One of the critical things about it is making sure that the providers are happy that we reviewed their patients. The last thing you want is for this to come across as punitive or something that they should be ashamed of or afraid of. And so we invite the PCPs to the discussion. If they can't come, we actually find them afterwards and discuss our recommendation with them, solicit modifications to the recommendation. And it's not until they've signed off on the plan and agree to it that we then place it in the electronic medical record and make it official. So we never want to force our recommendations on anyone. It's much more of a teaching tool. The last strategy that I wanted to share with you that we have found to be extraordinarily helpful in teaching residents about this issue is our chronic pain group. So I'll tell you, I have been trying to help people with chronic pain for nearly a decade, and the most useful thing I do ever is this chronic pain group. It's one of the few things that really genuinely impacts people's function in addition to their pain scores. So our chronic pain group is a combination of cognitive behavioral therapy and acceptance and commitment therapy. So I think most of you are probably familiar with cognitive behavioral therapy, which works by helping people reframe their situation and manage their thoughts more effectively. Acceptance and commitment therapy is a little bit newer, and its foundational principle is essentially that if people can learn to accept, to really accept what's happening and where they are now, it allows them to commit to making it better in a more effective way than if they're fighting the reality of what's happening now. And as you can imagine, this is really, really useful for chronic pain patients. So we know that these kinds of treatments have better functional outcomes than opioids and equal or better pain management outcomes. So we love this treatment model. It has a lot fewer side effects than opioids. And what I'll do, I'll just walk you through what we typically do. We have a 12-session group. So 12 sessions is 1 dose. We let people repeat. If they want to repeat a 3rd or a 4th time, we do let people, if it seems like they're getting a lot out of the group, but we do encourage graduation after about 24 sessions. You can see I made a list of some of the topics. There are 12 topics: hope and acceptance, communicating with your healthcare team, the relationship between emotional and physical pain. You can see there are a lot of different things we talk about. And I'll give you a picture of what a typical group looks like. I'm going to skip that. So we start with 3 deep breaths, just to ground people. We do a little check-in where people tell us how they've been doing the last week. We then hit the topic. So in this example, how thoughts affect pain and how pain affects thoughts. We take a little stretch break because people with chronic pain can't sit very long. We do some kind of meditative exercise every week, whether it's a guided visualization, meditation, breathing practice. And then we give homework every week. So in this case, their homework is a specific exercise where they write down their thoughts and determine whether they're helpful thoughts or not helpful thoughts along the way. We wrap up with 3 deep breaths, and then we have every patient go around the room and tell us what are they going to take home from today? What was the most useful thing they got out of the group? It's an extraordinarily powerful model for people. Patients have said things like, I realized that I'm not alone. Nobody ever understood me, but now they do. I realize I still have pain, but I can live with it. It doesn't bother me the way it did. I have one patient who used to say, mind over matter. If you don't mind, it doesn't matter. That was her little quote at the end of every session. And this hope, I have hope now. I hear that all the time. Just knowing that there's someone who will listen to me gives me hope. And residents, too, find themselves more interested in chronic pain after the groups, more empathetic. They learn a little bit about group visits, which is really important and useful. And they say things like, I actually enjoyed working with chronic pain patients, something I never thought would happen. So I have found this, I have residents rotate through the group 4 weeks in a row, so they do 4 sessions. And it really transforms their relationship with their own patients who have chronic pain. So we're happy to host guests if people are in the area and want to come check it out. We also have a manual that we share freely, so feel free to email me if you have any interest in that, and then, of course, we'll have questions at the end. And now, without further ado, I'm going to pass this over to Soraya.
Great, thanks, Diana. Welcome to everybody, also that I can't see. I'm going to really sort of build on what Diana talked about and really focus on additional methods to use to teach our residents about opioid safety. And so without further ado, I'm going to go through 3 things. First is really just sort of classroom learning and more traditional didactics, because that is a sort of critical part of preparing residents to manage patients with chronic pain. I'm also going to talk about systems training and how we actually have built a chronic pain registry and use that as a tool to educate residents about how they're taking care of their patients on chronic opioid therapy. And then finally, I'm going to talk about a program that we started, as did Diana, at Family Health Center to provide intranasal Naloxone for overdose prevention for patients with chronic pain on chronic opioid therapy, and how this has also been a tool to have residents sort of think about and focus on safety. So first off, I think that the traditional didactics, in some ways, we're moving away from that in terms of education and thinking about novel ways to teach our residents complex content. But this is still really important and critical. And so the first chance we get, we start teaching our interns about chronic pain. And at UCSF, we have what's called the Intern Immersion Month. And so for a month during your intern year, as part of your ambulatory schedule, you participate in intern immersion, which really consists of lots of time in clinic, shadowing different members of the care team, learning ambulatory didactics, and also just learning about how clinic works. So basically there's a 2-hour sort of lecture focused on the burden of chronic pain, the unequal treatment of pain, currently where we think the evidence is for chronic opioid therapy in pain management, and then of course talking about risks and benefits. And then of course, lots of focus on our clinic systems of care. Similar to what Diane described, we also have sort of clinic policies and procedures for how we manage our patients that are on chronic opioid therapy. And so it's really sort of teaching interns from the get-go how that all works. So for example, when you sign your pain agreement with your patients, you need to do a warm handoff to pharmacy, and the patient will then return to the pharmacist for refill visits and so on. The other opportunity we have for teaching is through a pre-clinic conference series, which I think also exists at many other residency training programs, and we sort of picked some core topics and have just incorporated that into the annual pre-clinic conference agenda. So one is on the interpretation of urine drug screens, because that's actually something that people think they understand, but actually may not truly understand, and misinterpreting urine drug screens can actually lead to very unpleasant interactions with patients, and so that's sort of a core topic. Also, we do a session about sort of cases, and this is how to respond to concerning behaviors while preserving sort of the spirit and techniques of motivational interviewing, because I think, practically speaking, when residents are in challenging conversations, they need to have some tools about what to do next and whether they can shape the conversation. So that's also part of our pre-clinic conference series. We also, in our program, have a curriculum on SBIRT, which is screening, brief intervention, and referral to treatment. It's an evidence-based approach for the screening and assessment of patients with possible substance use disorders. That amounts to about 16 hours of didactic time, and this is something that's provided to second and third year primary care residents and a select number of categorical residents that are part of our social medicine curriculum because they have opted into that curriculum. In those 16 hours of curriculum, there's actually a really heavy focus on motivational interviewing. Again, it's really a skills-focused curriculum where we do sort of lots of role plays, lots of peer-peer feedback, and lots of sort of group exercises so that people can really build their knowledge together and think about good strategies that others may have used, and so it leads to a more rich experience as opposed to just PowerPoint-based teaching. And then we also have sessions on medication-assisted treatment, and we assign residents to go on site visits to actually see substance use treatment in action, so to speak. And then, of course, big focus is on chronic pain and difficult conversations. Again, there's so much overlap between chronic pain and substance use disorders that it sort of naturally comes up during the SBIRT curriculum. And then finally, for every single one of the UCSF internal medicine residents, there is sort of 1.5 hours as part of their core ambulatory curriculum that is devoted to a lecture on safe opioid prescribing. That I have the honor of giving, but that's another sort of way that we sort of provide residents with the training that we think is most essential. And I want to zoom in a little bit on our SBIRT curriculum and medication-assisted treatment. Essentially, as part of the SBIRT course, we also want to empower our residents to know what to do when they think that somebody does have an opioid use disorder. Essentially, we have this great service in San Francisco, which is the office-based buprenorphine induction clinic. And so residents can actually refer patients with an opioid use disorder to this induction clinic, and they will induce the patient on buprenorphine and stabilize their dose. And then actually the patient can return to primary care, and the resident can continue to provide the buprenorphine naloxone. And so as part of the SBIRT program, we have residents go to the OBIC clinic to learn about the services they provide, and then residents can also receive primary care referrals from the OBIC clinic. And this has been really nice because I think often residents, much like Diana said, you know, they are not jaded, they really want to help their patients, and when the conversation involves saying no to ongoing opioid therapy, it's nice to provide an alternative treatment. And so if we think a person does have an opioid use disorder, the alternative treatment we can provide is buprenorphine naloxone. And so that can provide sort of this opportunity to offer something in addition to the multidisciplinary treatments that Diana described. So that has been very popular among residents. There's also a lot of informal teaching, as we all know. Often if there is a faculty member that is interested in chronic pain and substance use, residents will bring cases to that person and talk about what their next steps might be in the management. That's a rich opportunity for learning. We also have a primary preceptor assigned to each resident, and the primary preceptor can help do chart reviews for patients that are complex, as does sort of the physician lead for chronic pain. We have occasionally observed residents during their visits with patients talking about pain. This happens in the context of the expert month so that we can see if they're using some of their motivational interviewing skills. And then in our clinic, we also have a controlled substance review committee, and residents are able to attend the actual review sessions. They also may refer their patient and receive the recommendations from the committee, and that sort of initiates a dialogue between sort of the resident and the committee in terms of, you know, what happened with those recommendations. Were you able to have any of those happen? What was the response from the patient? That's been really helpful for residents. And then finally, we do have an ambulatory M&M that focuses on outpatient cases, and some of these have actually focused on patients on chronic opioid therapy. Now, I'm going to switch gears a little bit and talk about systems training and our registry. We decided that we need to essentially take care of all of our patients on chronic opioid therapy and do safe population level health management for them. And so we define our chronic opioid therapy patients as anybody taking medication for greater than or equal to 3 months. And those people are assigned an ICD-9 code, and that having that ICD-9 code in their problem list transfers them into our registry database, which is called I2I. Our EMR is called eClinicalWorks. And this allows us to track several things for this population of patients. For example, their last urine drug screen, the date of their last pain assessment and agreement, their morphine equivalent dosage, and then any other sort of risky elements, for example, if they are also prescribed benzodiazepine. The registry has been helpful. It allows us to generate quality metrics that we report to the health plan as part of our pay for performance goal related to chronic pain. More specifically, we generate a number which is the percentage of patients in our registry who have both an up-to-date pain agreement and urine drug screen. And we have tracked this number over time to see how well we're doing. You can also generate individualized provider reports, which I will show everyone, but it's a list of all of my patients that are on chronic opioid therapy and all of the characteristics that I described. And so it sort of serves as an individualized report card to have you sort of think a little bit about who's on that list. How well do I have a handle on what's going on with them? Oh, wow, look how high their dosage is. Maybe we should do something about that, et cetera. And this really facilitates outreach to patients. You know, is this a person that is taking a lot of medication? I actually haven't seen them in a while. Like, I need to see that person. We need to sort of re-sign their pain agreement and maybe talk about some of the potential risks of high dosage therapy, for example. And again, it also tells us if people have been out of care. So this is a little bit difficult to see, but you're going to have to pretend that these two big boxes actually are side by side. And so starting in this this first one, you basically see a list of the names of all the patients. So this is one provider's report. So this is the name of all of our patients on chronic opioid therapy, and then moving to the right, their medical record number, date of birth, who the provider is, what their insurance plan is, some demographic characteristics for the patient, and then at the far right, what's their morphine equivalent dosage. As you can see for this provider, she does have one patient that's on 366 milligrams morphine equivalent dosage, which is considered quite high. And then you can see here, moving to the box below that, has this person also been prescribed benzodiazepines, yes or no? When's the date that they signed their pain management agreement? And then the date of the cocaine screen is a surrogate. That's also the date of their last urine drug screen. And then, of course, whether cocaine was present. We also have a field for whether or not a person's been prescribed intranasal naloxone, which I'll talk about. And then when was the date of their last cures report, and then when is their next appointment. So again, lots of information that we can provide to report to providers, and we try to do this on a quarterly basis. Finally, I'm going to talk about a program that we started that really is focused on opioid safety, which was providing intranasal naloxone for overdose prevention. As Diana alluded to, really we've noticed that we're in the midst of an epidemic of unintentional overdose from chronic opioids or opioid pain relievers, and you'll see here this was sort of the MMWR that came out in 2011, really characterizing this new scourge of overdose. And to the right, you can also see this is from Philip Coffa, who is in our Department of Public Health Division of Substance Abuse Research, looking at San Francisco data. And what we saw is that we really had this, have had this nice decline in heroin deaths, largely due to distribution of naloxone, but we've had this steep rise in prescription opioid deaths. And so the idea is that patients taking prescription opioids may not, for example, identify with a current or prior history of a substance use disorder, and, for example, may not go to a needle exchange program and would not think that that is something that applies to them. And so the idea was, how could we capture this group of individuals that is at risk but doesn't have access to the life-saving medicine, which is naloxone. And so in collaboration with the Department of Public Health, we started providing naloxone to patients taking chronic opioid therapy. Essentially, the Department of Public Health was instrumental in terms of negotiating with insurance plans, primarily our managed care Medicaid plans, and then our Healthy San Francisco plan, which covers the uninsured, to make sure that naloxone would actually be covered by insurance plans. And so once it was established that this was actually covered, from the clinic side, what we did is, so let me briefly sort of explain. Right here in the center of your screen is the box, and naloxone comes in a pre-filled syringe. And so right to the right of that, you'll see a little glass vial with a red top, and that actually is a liquid that contains the naloxone. And then to the left of that is basically allows the atomization of the medicine. And so below, this is actually the instruction of what happens. You take off the yellow caps, and then you take off the red cap, and you screw the red cap into the plastic dispenser, and then on top you put this little triangle-shaped thing, which is called a nasal atomizer, and that actually allows you to push on the bottom of the device, and it creates this big magical spray of naloxone that can be sprayed up somebody's nose. And so in primary care, what we did is we created, and you'll see that to the left, we had these so-called kits that actually just consisted of a plastic bag that had stamped to the front instructions for the provider on how to actually prescribe naloxone in the EMR and how to write it, because it was very often, naloxone is not something we write for like we do benazepril, and so how to actually write the prescription. And then in that plastic bag were 2 atomizers, because when you write the prescription, you give somebody 2 boxes of naloxone. And that's because if you are giving it to somebody in case of an overdose, after 5 minutes, if you've seen no response, you can actually administer a second dose. So people were dispensed 2 boxes of the naloxone, and in the kit there were 2 nasal atomizers. And so providers basically would write the prescription and send it to the person's outpatient pharmacy, and then they would teach the patient with a training kit how to use the intranasal naloxone. This is sort of the workflow that we began with. We have since changed it. Essentially, provider would identify the candidate patient, which in our case, we said any person taking chronic opioid therapy in the registry is a candidate for intranasal naloxone. The provider then prescribes the medication, and the provider does the training for the patient and or the caregiver and gives the person the kit. The patient picks up the medication, and then provider manages any problems related to the prescription and follows up with the patient. As I'm sure you are all thinking, this is pretty labor-intensive for the provider, and so that has probably been one of the barriers to roll out. And so here we actually, as sort of a mini QI project, we sort of said, well, how well are we doing in terms of cumulative number of naloxone prescriptions after our launch? And as you can see, there was a gradual but slow uptake. And so essentially we started educating providers about doing this. Then we actually gave them feedback in the using our registry. We gave them their progress reports and showed their patients and what morphine equivalent dose the person was on and whether or not they had been prescribed naloxone, so that providers could actually see how many of their people didn't have access to the medication. And then we did repeat education launches and then panel reports. And essentially over about a year, we actually only got to about 25% of registry patients that received naloxone. And if you see here, the breakdown is that actually 78 were given to pain management patients, but 28 were given to other patients, and those were people with any history of overdose or individuals with an active substance use disorder. And so while you can say, oh, well, you only really got to 25% of patients in a year, I think that this still represents an important start. And also we were providing this medication to people that had active substance use disorders. And so since then, we continue to work on the educational effort, and these numbers have since increased, but it can be a slow process of uptake. Thinking specifically about intranasal naloxone and residents, the residents were actually early adopters of prescribing intranasal naloxone. Attendings were a little bit more difficult to reach, but it gave them important teaching in how to talk about opioid safety and how to talk about the actual risks of these medications. And, they hadn't really thought about this because many of our residents do a lot of inpatient medicine where opioids are used more liberally, and you don't have as many discussions about risks and benefits. And so this really gave them experience in just sort of saying, hey, I'm worried about you. I need to give you this medicine. Let's also talk about your dosage, and maybe we should gradually wean it down. And so that's been helpful for them as a way of sort of conveying how much they care about their patient. They've actually been so excited about intranasal naloxone that it's actually spread to the hospitalized patients at San Francisco General. And this was a sort of resident-driven QI project, basically to provide intranasal naloxone to hospitalized patients that were being discharged from the hospital. And so anybody was eligible if they had a history of overdose, an active substance use disorder, or were on chronic opioid therapy and at risk for misuse. And so to the right, you sort of see this was an example of one of the sort of educational posters that the residents designed and sort of put up to sort of increase awareness about the use of naloxone. And so that intranasal naloxone in the inpatient setting has also been has sort of taken off as well, and many patients leave the hospital with prescriptions. Nicely, in the inpatient setting, the physician writes the order for naloxone as a discharge medication, and the nurses will do the teaching prior to discharge. And so just to thinking about lessons learned and some take-homes, you know, my perspective is that you really have to incorporate traditional didactics on chronic opioid therapy. Our residents don't get this in medical school. They definitely don't get taught it well. And you should always sort of expect that there's sort of no understanding of this when they come to residency. And it's difficult because as soon as they start residency, they get transfer patients, so-called these inherited patients on very high dosages. And so they need to have some tools and some baseline knowledge that they can use to handle what can be difficult conversations. I also think it's important to elevate the topic. You know, chronic pain should just get just as much curricular time as heart failure or sort of sepsis, and I think introducing rigor and showing the actual evidence base is something that really resonates with our trainees. And then also, I think my advice to anybody is to include lots of skills training. Again, what am I going to say when I'm in the room and I'm having a difficult interaction? And that's the part that where residents need help. It comes with experience for many of us, but you can simulate situations and they can learn to find the language. And then a disease registry can be extremely useful to both understand the burden of disease and to reach patients and to think about how you're doing yourself in terms of managing patients on chronic opioid therapy. And so I'd be happy to talk offline with people about what that looks like and how we are able to maintain it in terms of time and resources. And then finally, intranasal naloxone was a great program in terms of teaching residents more about opioid safety and building on conversations with patients about risks and benefits of treatment. So now I'm going to hand things back to Christine, and I believe we'll have some time for question and answers.
Yes, we do have some time for that. Thank you so much, Soraya and Diana, for both of your excellent presentations. I'm going to ask Canel to open up the lines for anybody to ask their questions in a second. You're also free to continue to chat your questions in the chat box, and we'll collect those as well. I did get a few comments and questions from Steve Steinberg. and I'll just read them to you, but Steve, you're also welcome to pipe up. One comment he made was that many residency programs don't have access to pain management physicians, and so I don't know if you have advice for such residency programs.
I will speak. This is Diana. We also, well, we don't have a pain management physician either. We have me, I'm a family doctor who got interested and so started seeing patients. And so I don't think you need somebody who's done a fellowship or somebody who's, you know, board certified as a pain specialist. I think you just need somebody who is interested enough to put in a little time to giving attention to these issues.
Okay, great, Diana. That's super helpful. And then another question from Steve is, what are your feelings on Suboxone off-label for pain? I know that you addressed this a little bit already, but do you want to share a little bit more?
Soraya, do you want to take that?
Sure. I think that increasingly there's lots of interest in buprenorphine naloxone for the management of comorbid pain and opioid dependence. And I think that there's an evidence base for this, that it can be extremely useful. And I think we have tried to provide that as an option for patients that are, again, having trouble managing full agonists for their pain. I will say that there are some patients that are on very high dosages of full agonists, opioid therapy, and are having concerning behaviors. And transitioning those people to buprenorphine naloxone can be a little bit more complicated. So I think increasingly there's some interest in, you know, if I have a person with a history of a substance use disorder who also has chronic pain, you know, might starting with buprenorphine naloxone be a better option. And so I think that I think it's an exciting new therapy that we can offer for patients, but we will still have a population of people that are on full agonists and who can be complicated to manage. Having said that, if we do determine that they have a severe opioid use disorder, buprenorphine naloxone would be an agent that we could use for both their dependence and their pain. Anything else you'd like to add, Diana? I think I just want to caution people against buprenorphine naloxone is not, for example, the simple answer for, quote, difficult chronic pain patients on opioid therapy, but I do think it does provide sort of another treatment option for some individuals.
Yeah, I agree. I think it's very interesting as a first line maybe in people who are high risk. It's not something that has become standard of care yet. Or maybe even necessarily will, but it definitely has the advantage of being much harder to overdose on, and a little less dangerous in the setting of diversion even too. So it has its place, I think. We haven't quite figured out what that place is.
Okay, great. Thank you both for that response. I want to just remind everybody that we do ask you to fill out an evaluation, so you should have seen that pop up in your bottom right corner of your screen. We'd love your feedback. We do have several more questions, but I also want to mention that it's a little after 1:30, so this is sort of the conclusion of the formal part of our webinar. So I just want to formally thank both Diana Coffa and Soraya Azari for their excellent presentations today and sharing their expertise with us. And the recording will be available for this webinar in about a week, and we'll have that on our website. But Canal has, again, opened up the line, so you can just let us know if you have a question, but let me read a couple to you that have come through the chat. So one from Brenda. This is a question for Diana. How did your clinic get buy-in from attendings or your more experienced physicians who are set in their methods of managing pain and that may not be appropriate for pain management?
Yeah, that's one of the hardest tasks for sure. I'll tell you where we started. We started with we actually did some faculty development sessions where we didn't try to address head-on people's own pain management practices, we addressed how are you going to precept about pain management. And in the context of precepting, it's really clear to attendings that they need to all be on the same page. So people are more willing to make some sacrifices and some concessions when they really recognize how important it is to all be on the same page. So we started with those conversations. What can we all agree on as preceptors? And what we ended up coming up with some basic principles as a group that we could all agree on. And then we ended up agreeing as well that if a resident had really thought through their plan, had discussed it with someone, and had a well-considered approach, we were going to let them continue with their plan. We weren't going to kind of yank them into our way if there was some discrepancy between preceptors. So we started with that conversation, and then over the course, literally, of a couple of years of continued conversation about it and this kind of iterative policy building, we were able to develop more and more actual clinical consensus in the clinic. We were very deliberate about including the people who were furthest from where we were trying to go in our conversations about the policy building so they could really hear the data and hear what we were thinking. And we still have some people who practice a little bit differently. We aren't completely 100% all on the same page.
Great. I think it's really helpful to hear that journey a little bit and that it does take some time and doesn't happen overnight. So that's very much appreciated. There's another question from Brenda for Soraya. She says, I missed the section about San Francisco DPH. Who paid for the naloxone atomizers?
It's a great question. We actually paid for it as a clinic. And when we started this, they were less expensive than they are now. Unfortunately, there's been lots of responding to the overdose epidemic has been this new growth industry, and that's why there's also now a new pharma product that is an injectable naloxone that's quite expensive. And the atomizers also have become more expensive, but we paid for it out of our clinic budget and continue to. And so I'd be happy to, if you want to email me, I can send you the information about where we order it from and what the item number is and that type of thing. Yes, there has to be some small fund of money that can support this.
And I will add that we did get Medi-Cal now pays for naloxone throughout the state. It's as part of the substance use treatment carve-out. So you do have naloxone covered, just not the atomizer.
Okay, great. Thank you. I just want to take a moment here and see if there's anybody who wanted to mention their questions out loud. I think your lines are open.
This is Ken Saffar. Can you hear me?
Yes,
Hi, Ken.
Go ahead.
Hi. Could you comment on the end of the year as we now enter the last days and weeks of R3s, how you transition patients who are complex, who've been engaged with their residents, hopefully, and have a management plan to either other residents or staff?
Soraya, do you want to
Yeah,
take
that's
that
a great question. I'll start and then let Diana go. We have a process of R3 transfers in clinic where people are designated as high risk or low risk. Chronic pain patients are almost always in the high risk category. And then we have sort of it's not a script, but we provide guidance on what your R3 transfer note should look like in terms of next steps for the provider that's inheriting the person. Occasionally, we also do warm handoffs for particularly complex patients. We have not required this, but I've noticed that many of the R3s that have patients on high dosage opioids have actually been referring the person to our Controlled Substance Committee for review and recommendations so that the new provider has those. Again, that's not required, but I think that, as you said, it's a really it's a difficult transition, but those are the structures that we've created. But I think what's really hard is that residents inherit patients, and then they get these lectures about opioid risk, and they start to sort of weigh those risks and benefits, and then they say, well, but I inherited this patient. I didn't start this regimen, and I think it's really hard to establish rapport with your new patient and then to introduce a conversation of let's weigh these risks and benefits together, and so that's difficult to do. Oftentimes patients may also no-show for their transfer appointment, but fortunately the high-risk ones we capture and call them and reschedule them. But I think that's what we've built up as for this handoff process, but it's a difficult transition.
Thank you. That's very helpful. And a great presentation, by the way.
Thanks, Ken.
There was another comment from Mimi. She was also wanting to receive the atomizer ordering information. So I think maybe we can, probably make that information available to all participants after the webinar.
Great.
Another question is, how do you get residents and attendings to accept the results of the review committee that you mentioned?
Yeah. So far, I don't know, sorry, our review committee has mostly run on referrals, so mostly people are asking for our help. We occasionally will dip into our registry and pull a patient out of that who's really waving a lot of red flags. But because the culture is really that people ask us for our help, for the most part, they're generally really grateful for the recommendations. And then because we have this process of having a conversation before we make the recommendation official, I think it makes it much less threatening. I don't know, Soraya, if you have other points.
Yeah, I mean, I think some residents are much more inclined to follow the recommendations. A lot of people, if anything, are asking for more. They want to blame someone else. So the committee sort of serves as a scapegoat. This is, the committee is making this recommendation. It's not me, because providers don't want to be sort of blamed by patients. So I think it's been helpful in those cases. But sometimes people, get the recommendations and they decide not to follow them. And we actually give people the option to put it in the chart or to not put it in the chart. I think, Diana, you guys might put it in the chart for everyone, but it's a difficult process. The committee recommendations are also meant to introduce a conversation about the person, and let's check back in about what's going on and how have things evolved, and also do you need some support? Like, do you need somebody from that's does more of sort of the pain stuff come and help you navigate sort of this difficult situation? So that's sort of my take on that.
Great. Again, another pause to see if there's anybody else who has any more questions.
Hi, this is Steve Steinberg. I just have a comment, but a question for you. We have been recommending in Kaiser Permanente, Southern California, expanding the ordering of urine drug screens to include the synthetic opioids. What are your feelings on this? The concept is that abuse has happened. If you're looking enough for if you're looking for illicit drugs of abuse, the rate of prescription drug abuse is high enough to justify ordering both tests. Curious what your thoughts are.
Yeah, we include synthetic opioids in our screen for that reason.
Okay, great,
Yeah.
great. Are you doing it by you must have the immunoassay test like we do, I assume, because the gas chromatography is awful.
Right. No, we have, well, no, actually we have the immunoassay, and then if it's positive for opioids, we do reflex liquid chromatography, HPLC, I think.
Right, but for the you do right. Some of the areas are only doing. I've been to a bunch of residency programs. And they're at some of these smaller programs. They only have access to a urine drug screen with opiates, specifically the codeine family and the oxycodone family, and no inexpensive access to synthetics. So.
Right.
I've been recommending that they get that access. Sounds like you've done the same thing. Thanks.
Yeah, I think it's important. We still miss fentanyl. But we catch.
Oh no, we actually are picking up fentanyl, and we're about to add. Interesting enough, we're going to add norhydrocodone, which is a late metabolite of hydrocodone. So the people who are abusing hydrocodone and then stop it prior to the urine drug screen will pick it up. We're getting that by the end of the year.
Great.
Yeah, we don't have that capability, but we definitely, as part of our initial screening immunoassay, another important synthetic, of course, is methadone, because patients may not disclose whether they're in a methadone treatment program, and we obviously have assays for oxycodone and oxymorphone. So.
Right, we've picked up since we started recommending to the docs to do routine urine drug screens, including the opioids, it's surprising how many people are being prescribed one drug and have a second drug in their system and not the first. We think there's a lot of buying and selling one to buy another. Seems to be a not uncommon practice.
Yeah, I think that's right. The other thing you want to be sure of when you are getting into the more complex opioid screens is that your providers understand the metabolites, so they're not misinterpreting a urine drug test as negative or positive when in fact it's an expected metabolite.
Right, we've had that problem with people getting Tylenol with codeine, and they get a metabolite for Dilaudid, and they'll call the patient up and accuse the patient taking Dilaudid, and we all know it's and it's one to the other. And there's some other interesting stuff about interactions between oxycodone, oxymorphone, and the other opiates, but. Yeah, I have a slide on that in my presentation. Say memorize this slide because you need to know your metabolic pathways in order to interpret this.
Yeah, I mean I think that urine drug screens have become more sophisticated because of again because of this epidemic and how liberally providers are still giving out opioids, and so I believe actually in our lab too, we're actually getting some new testing that's more sensitive, and I encourage anybody that's listening to, if you are sort of the point person for this, is to form a relationship with your lab so that you understand what methods you're using and how to interpret your screens. So.
Great, thank you, Steve, for those questions. Are there any other questions from people? One more question. Can you share a little bit about how you know your protocols are being followed? How do you monitor that, and how do you have conversations about that with you?
So really, it comes down to the registry, and you treat it like any other quality improvement program. So if you're recommending annual urine drug screens at a minimum, for example, you can look at your registry and see if that's happening. It's harder for us to track things like, you can also look and see how many of our patients have positive cocaine in their urine but continue to get prescriptions. So it's really those panel reports that are helping us track. I think, Soraya, you're probably in a similar situation.
Yeah, I mean, and by no means are we perfect. So, our quality metric is how many patients have an up-to-date signed pain agreement and urine drug screen in the past year. And, we've just gotten to 60% of patients in our registry. So, by no means, and of course, but our quote, procedure for our clinic, our policy, you know, is that people re-sign their pain agreement on an annual basis. Part of that is because many patients may not know that they're on a pain agreement. And so, you know, that's our standard, and it's hard to accomplish that. And so we actually have a pre-medical student that helps volunteer with us and actually sends reminders to providers that they need to re-sign their pain agreement. So that's sort of just a workaround that we've created to really try and get up our numbers. I think the issue, of course, with chronic pain patients, there's always sort of competing issues. You know, how am I supposed to sign a pain agreement if the person's sugar is 300 in clinic or whatever? And so that's always been sort of the biggest challenge.
This is Ken Sapphire with another question. Do you have any advice or suggestions or strategies to deal with the opioid-phobic either providers or preceptors in dealing with, you know, the residents that they invariably interact with?
Diana and Soraya, did you hear that question?
Yeah, no, I think it's a great question, because just like Diana said, the pendulum is swinging, and some people are swinging very very dramatically against opioids and almost saying, well, I'm never going to give opioids, and so I think for those opioid-phobic people, I think engaging them sort of in conversation can be helpful, and trying to, you know, sort of figure out what their reluctance is. If opioids might be a beneficial therapy for the person, you know, it's one thing to just say, well, I'm not giving out opioids. It's another to say, I don't think opioids are safe for this person, and so I want to work on like these 4 other multidisciplinary ways to control their pain, and if that doesn't work, you know, reevaluate and again weigh the risks and benefits of opioids. You know, so I think that it just this chronic pain will continue to live in primary care. We cannot refer all of these patients to pain management specialists. The burden is just too large. And so I think we all just need to sort of improve our knowledge about what we can offer patients that's not opioids or that's used in conjunction with opioids. And so that's sort of my perspective on this.
Yeah, one of the most powerful things, as I mentioned, for us in training is really bringing people into the pain group. Once a resident has spent, 6 hours listening to people talk about how pain has changed their life, it becomes much more difficult for them to have such black and white thinking about treatment options. They realize that they really need to go ahead and dive into the nuance because their patients need them to be creative.
Okay, thanks.
Thank you. Are there any other questions?
Yeah, this is Steve Simon. 2 quick questions. One big part on the same subject the person just called. Is there an MED count that you feel is not within the scope of primary care? We've been arguing about this in Southern California, and the feeling is somewhere around 300 to 500 might be beyond the scope of a primary care physician. That's question number 1. And the second question, which is San Francisco County, has there been any discussions about following the lead of LA County, Imperial, San Diego, and now Riverside and San Diego are getting all the ERs together to stop the use of injectable opioids in the ER for chronic pain patients' exacerbations? 2 questions. First, is there a MED count you might consider beyond the scope of primary care? Second question is, has there been any talks in San Francisco County about following the lead from the counties in the south?
So I can speak a little bit to the emergency room, although, Soraya, I know you were involved in some specific work with the emergency rooms in this area. I always shy away from the black and white, no injection opiates for somebody who's having a flare, because for all you know, somebody's having, pancreatitis on top of their chronic abdominal pain. And I do think we need to leave some room for clinician judgment about what the right move is. But Your second question, or your first question, was about dose, right? Is there a dose after which the primary care provider is no longer right the person? That's a really interesting question. I mean, there's all kinds of argument right now or discussion about whether there should be dose limits and what the dose is. And the truth is we're in a little bit of a data-free zone. We know that as the dose goes up, the risk of overdose goes up. We actually have some evidence that there's no increase in misuse as the dose goes up. It's not like it's a marker for addiction or misuse, but it is a risk factor for overdose. Do specialists prevent overdose better than primary care doctors? Maybe. Maybe they escalate doses faster. I think it depends a lot on the specialist. So I feel like we don't have a lot of data to support us, but I think most primary care providers would say after it gets above 200, 300, 500 milligrams, I feel like I don't know what I'm doing anymore. I think that's fair, but it's not an evidence-based recommendation.
Right. If you look at, for instance, the Dunn study, unfortunately, they don't break out a relative risk above 100 MEDs or greater. I would have loved to have seen that,
right. Well,
but I have not seen any published studies.
If you actually look at their data points, it's a linear progression. There's no inflection point at which the dose starts to rise. Once you get over 5 milligrams a day, every step of the way up, your risk of overdose increases. There's no magic dose.
Right.
Yeah.
Yeah.
All right.
We're running out of time. The last thing I'll say about the emergency department is we did a very informal version, which was reaching out to ERs and trying to have a session with them to talk about chronic pain, but there have been no structural changes like there have in other counties or like there has been in New York in terms of, it's only 3 days of meds, and none of that has happened, but we did reach out to several ERs to talk about the interaction between the ER and chronic pain patients.
Great.
Well, I think we're going to have to draw this one to a close unless there are any, if there's a final burning question that anybody has. No? All right, well, I want to first thank our webinar attendees so much for your time and your participation and all your great questions. And then again, to thank Drs. Coffa and Azari for your excellent presentations. We've all learned a great deal from your presentations. Thanks, everybody. And we can close now. Have a great rest of your day.
Thank you.
Great, thank you.